in patients with prominent rims and deep set eyes because it looks bad. It looks bad. So I would never raise the brow on this side eye of mine. Brow lifts will often accentuate the deep sulcus and the hollow eye. So if you look over time, the shape, height, thickness, and orientation of the eyebrow is somewhat cultural, but beauty is cross-cultural. We know when things look pretty, but we also know when they don't look right, like this. Okay, this is Sylvester Stallone, Rambo. Why do his brows look bad? He's had a lot of plastic surgery in his life. Why do his brows look bad? Because it exposes his skeletonized orbit, and that doesn't look good to us. Our eye says that does not look good. Okay, anatomy. I may skip this because Sebastian's better at this than I am. So, let me just go through this real fast. You don't really need this stuff. I could talk, let me tell you what are the important things relating to brow lift. I could talk about the anatomy up here all the time. But there are two important things. It depends on how you do the brow lift. So if you do a brow lift like just described through the eyelid, you're leaving the periosteum down. That's the fixed area that you're fixing to, and you're lifting up the soft tissue 1, 2, and 3 on 5. 5 is the periosteum, okay? You're leaving it that way. But if you're doing it how I'm going to show you, which is not better, it's just the way I do it. If you go underneath the periosteum, you've got to cut back through the periosteum to make that work. That's where the arrow is at the arcus marginalis, okay? So there are two important areas, the arcus marginalis and the conjoined tendon. I'll get to those. So you don't need these. I'm taking too long, and I don't like taking other people's time. So let me skip the anatomy unless you're begging. You need to think about the corrugator and the orbicularis. You need to think about these muscles. And okay, so let me skip forward. Okay, temporal anatomy. All right. Sorry to do this. Okay, so let's talk about the dynamics and what we do exactly. So the way I learned to do brow lifts was to go, get that pointer, just throw it, I'll catch it. The way I learned to do brow lifts was to go, underneath, it's going to slip off here if I let it go. I don't want my computer to slip on the floor. Yeah. So we leave the periosteum down and we go underneath of the galea. That was the normal brow lift that we all got taught. Okay? And that was the sliding thing of leaving that down. The fixing of that was re-putting back together the galea. It was the re-putting back together that created the brow lift. But the fallacy of that was we did the biggest resection in the center, which left the center brow more. And we want the lateral brows to go up more. So the endoscopic lift, you theoretically can get the vector point wherever you want, and you go underneath the periosteum. But you've got to shift back to an area that is going back through the periosteum. Now, my artist drew this many years ago, where it was above the eyebrow. This periosteal release should be below the eyebrow. It should be at or below the eyebrow. Thank you. So the endoscopic lift for me is simple. I'll show a few slides of it and then a couple of results. Should be a video. So there are two anatomic release points, and the reason there are release points is you're changing plane. You're subperiosteal here, you're subgaleal here. You're changing plane. There are two anatomic release points. One is the breakdown of the conjoined tendon. We all know that. Sebastian described it very well. It's breaking down this conjoined tendon as you see in the anatomic things. So that's number one, breaking that down entirely. And number two, and you can do that with light or without light. The way I do it is I join the tunnels and I turn my elevator on its side like you're edging a ski. And I edge from above down, and you're safe because you're right on the bone, carefully. And this is what that looks like. Medially, come on, play. You played before. These are like, so this is medial on the left, lateral on the right. You're breaking down the conjoined tendon. You can see the temporalis muscle on the right. That's all. It's easy. And then, number 2 is complete division of the arcus marginalis. Complete division from frontal zygomatic all the way to this side. Okay, and the way that looks is this. So we're above here, we spread that, we push down, and we break through that area. And what you're going to see is the roof of the orbit fat. Not the roof fat, but the roof of the orbit fat. So the way that is schematically, when we look at that, is we're breaking this conjoined tendon that is right here. We see the nerves, we break through the conjoined tendon. I don't like to skeletonize the nerves. You can do that with a scissors, you can do it with an elevator. But I like this schematic. So the nerve is in here, this is lateral to the nerve on the left side, and these are the 2 edges of the periosteum. And we're looking into the orbit from above. It's actually quite easy. Okay, so these are the 2 important release points. The conjoined tendon, the arcus marginalis. What about fixation? I use this little bone bridge that I designed. It's very simple. It makes a trough in the bone. I'm almost done. And then I have a suture passer that grabs it. The way I do it today is this is perpendicular to my incision. My incision is this way, and my trough is perpendicular. That's an old slide. Here's how it looks. We drill a hole on one side, then we put a pin in so the thing does not move. Then we drill a hole on the opposite side. The suture passer goes through. It's sort of an elegant, cool little design, even though I made no money on it. And then we pull the suture back. It's fixed in the bone, and we can pull the whole skull up on that. And then we tie it to the flap. And I might use 1 or 2, and then I close the wound. In the temple, I go from the temporoparietal fascia to the deep temporal fascia. Very simple. Here are the results, the kind of results I get. We want a lateral lift of the brow. That's what we want. If the lateral brow is above the medial brow, it looks better. Or we just want to fixate the brow so it does not come down with the aggressive blepharoplasty. Like this. It's not that the brow needs to be so much higher, but that would require an aggressive blepharoplasty. And if you did it that aggressively, the brow would come down. We all know that. And brow lifts work the best on this lateral skin. They really work the best on the lateral skin. Or like this, somebody that I just did, I would have rather relaxed her medial brow. You don't want to pull, the medial brow is deceivingly easy to raise too much. And the lateral brow is deceptively hard to raise enough. I will say that again. It took me many, many years to know this concept. The medial brow is deceivingly easy to raise too much. And the lateral brow is deceptively hard to raise enough. Okay? If you can remember one thing, remember that. My brow take-home points are these. Attractive periorbital appearance is not related to absolute brow height. It's not related to that. Anybody can take a picture of this if they want. Brow shape is more important than brow height. Shape is more important than height. Brow lifts should be avoided in skeletonized orbits. Success in brow lifting is related to release, not fixation, and adequate release requires division of the arcus marginalis and division of the conjoined tendon. Thank you.